Hi, this is Tammy McClish. Let's go ahead and take a look at radiographic shoulder girdle positioning. Here is a shoulder girdle. We want to make sure that we are imaging the humerus, the scapula, a portion, if not all, of the clavicle, and if possible, on some x-rays, we will also x-ray the acromioclavicular joint and the sternoclavicular joint. Now, when you are x-raying a shoulder, if you have a patient that is larger than 10 centimeters, you will use a grid. And if you are using a grid, then you will use 70 kVp to 75 kVp. And if the patient measures less than 10 centimeters, then you will be taking these x-rays tabletop with a kVp of 60 to 69 kVp. All of the shoulder x-rays will be a 40-inch SID except for the standing view of the acromioclavicular joints, and that will be at a 72-inch SID. Whenever possible, try to use a small focal spot, but sometimes you're going to have to use a large focal spot if you think that there is going to be a potential for patient motion. Now, this x-ray here is an x-ray that is a neutral position. Reason being is that the patient possibly has a dislocation or a fracture. So at that point, we do not move the hand whatsoever. We do not move the arm. We're going to have the patient erect or supine with the arm slightly abducted. The arm is going to be in the neutral position, and our central ray is going to be perpendicular 1 inch inferior to the coracoid process. Now, it's kind of difficult to palpate the coracoid on all patients, so you want to go a little bit lower than the clavicle and about the level of the humeral head, and that's where you're going to position the patient. Now, more often, you're going to be taking this x-ray, which is an AP shoulder with an external rotation. The patient is going to be supine or erect with the arm slightly abducted. You're going to rotate the arm externally until the hand is supinated and the epicondyles are going to be parallel to the image receptor. The central ray is going to be perpendicular 1 inch inferior to the coracoid process. Now, when you're looking at the x-ray, the proximal humerus and lateral 2/3 of the clavicle and upper scapula are demonstrated. The greater tubercle is visualized in full profile laterally, and the lesser tubercle is superimposed over the humeral head. There is sharp tissue detail and sharp bony trabeculation are clearly demonstrated with no motion. Here's an AP shoulder x-ray that is internally rotated. Once again, the patient is erect or supine with the arm slightly abducted. You want to rotate the arm internally until the hand is pronated and the epicondyles are perpendicular to the image receptor. And the central ray is going to be perpendicular, same spot, 1 inch inferior to the coracoid process. When you look at the x-ray, you want to have the proximal humerus and lateral 2/3 of the clavicle and upper scapula. The lesser tubercle is going to be visualized in full profile medially. And the greater tubercle is going to be superimposed over the humeral head. You're going to have sharp tissue detail, and sharp bony trabeculation is clearly demonstrated with no motion. Here's an x-ray that is not taken that often. In fact, this is something I learned back in training. It is an INFEROSUPERIOR axial, also called the Lawrence method. Patient is going to be lying down on the table. The affected arm is going to be abducted to a 90-degree angle, and you're going to rotate the hand externally. The image receptor is going to be placed on the superior aspect of the shoulder, and it's going to be pushed into the crook of the neck. And the central ray is going to be horizontal, directed 25 to 30 degrees medially to the axilla. When you're looking at the x-ray, the lateral view of the proximal humerus is going to be in relationship to the scapulohumeral cavity is going to be demonstrated. The spine of the scapula is seen in profile inferior to the scapulohumeral joint. The affected arm is abducted about 90 degrees. And you have soft tissue detail and sharp bone trabeculation is going to be clearly demonstrated with no motion. Here is another x-ray that you don't see often. This is a PA TRANSAXILLARY, also known as the HOBBS modification. The patient is going to be standing or lying down prone. You're going to raise the affected arm superiorly and fully extend the arm. The central ray is going to be perpendicular to the image receptor, centered to the glenohumeral joint. And when you look at the x-ray, you're going to see a lateral view of the proximal humerus in relationship to the scapulohumeral or the glenohumeral joint. The coracoid process of the scapula is seen on end, and the affected arm is elevated completely. Soft tissue and sharp bony trabeculation are clearly demonstrated with no motion. Here is an x-ray that is taken frequently. This is an AP oblique of the shoulder, which is also called the Grasheey method. Patient is going to be supine or recumbent. They're going to be oblique 35 to 45 degrees toward the site of interest. The hand and arm is going to be in a neutral position. And the central ray is going to be parallel to the mid-scapulohumeral joint. When you look at the x-ray, you will have a view of the head of the humerus in relationship to the glenoid cavity, open scapulohumeral joint space, anterior and posterior ribs of the glenoid cavity are superimposed, and soft tissue margins and sharp bony trabeculation are clearly demonstrated with no motion. Here's another x-ray that is not taken often. This is called a tangential view of the shoulder, or the intertubercular bicipital sulcus, also known as the FISK modification. Patient is going to be supine. You want to abduct the arm slightly, supinate the hand. The central ray is going to be 10 to 15 degrees down from horizontal, centered to the groove. And the image receptor is going to be vertical against the top of the shoulder. When you're looking at the x-ray, you're going to see the humeral tubercles and intertubercular groove is going to be seen in profile. There will be no superimposition of the chromium process. And you will have sharp borders and sharp bony trabeculation, clearly demonstrating the intertubercular sulcus, which is seen through soft tissue with no motion. Now the same is true for this x-ray, but there's a little bit of a difference in the way the patient is positioned. The patient is going to be prone, but they're going to lean forward about 15 to 20 degrees, and your central ray is going to be vertical to the image receptor. Here's another x-ray that is taken quite often. It is a PA oblique of the shoulder. Now this view can be taken AP also, but this is called a scapular Y lateral. The patient is going to be erect or recumbent. In this picture, they're PA. You want to rotate the affected shoulder into a 45 to 60 degree posterior oblique. The unaffected arm is going to be up and the affected arm is going to be down. And the central ray is going to be perpendicular to the scapular humeral joint. When you're looking at the x-ray, you have a true lateral view of the scapula. Proximal humerus is also demonstrated. You have a body of the scapula seen on end without rib superimposition. The upper limb is not elevated or moved with possible fracture or dislocation. And bony margins are clearly demonstrated with no motion. Here is another x-ray that would be taken if the patient has a suspected fracture. This is a transthoracic lateral, also known as the Lawrence method. Patient is going to be supine or recumbent. You want to place the affected part adjacent to the image receptor. Ease the uninjured arm and rest the uninjured hand on the head. Elevate the uninjured arm as much as possible. And the central ray is going to go through the thorax to the surgical neck. When you're looking at the image, you're going to have a lateral view of the proximal humerus and glenohumeral joint. The shaft of the proximal humerus can be clearly visualized, and the humeral head and the glenoid cavity are visualized. The ribs and lungs should be blurred due to a breathing technique, but bony outlines of the humerus should be sharp indication that there is no motion. Here are two x-rays of the clavicle. One is an AP on top and the one on the bottom is an axial. In the top x-ray, the patient is either erect or recumbent. You need to center the clavicle and the image receptor midway between the jugular notch medially and the AC joint laterally. And then the center ray is going to be perpendicular to the mid-clavicle. In the bottom image, you're going to angle the x-ray tube 15 to 30 degrees cephalic. And then you're going to center the central ray to the mid-clavicle. Here are two x-rays of the scapula. The top is an AP, the bottom is a lateral. Patient is supine or erect. You abduct the arm 90 degrees, supinate the hand. Send into the image receptor an entire scapula to the central ray. And the central ray will be perpendicular to the mid-scapular or 2 inches inferior to the coracoid process. When you're looking at the x-ray, the entire scapula is demonstrated. The lateral border of the scapula is free of superimposition, and the sharp bony borders and trabeculation are clearly demonstrated with no motion. The bottom x-ray is a lateral. Patient could be erect or recumbent. Palpate the borders of the scapula and rotate the thorax until the body of the scapula is perpendicular to the image receptor, which is about 45 to 60 degrees. Central ray is perpendicular to the mid-vertebral border of the scapula. And you will see the entire scapula in a lateral position. The humerus is not superimposing the region of interest. The ribs are free of superimposition by the body of the scapula. And there are sharp bony borders, and trabeculation is clearly demonstrated with no motion. The last x-ray is AC joints with and without weights. Now this is the only x-ray that will be taken at 72 inches instead of 40. The patient could be standing or seated. Arms are at the side. One exposure is going to be taken with weights and the other will be taken without weights. When you take the one with weights, you want to make sure the patient is holding 8 to 10 pound weights. The central ray is going to be perpendicular to the midpoint between the AC joints, about 1 inch above the jugular notch. And you want to have both left AC and the SC joints. No rotation, symmetric SC joints, and the bony margins and sharp bony trabeculation are clearly demonstrated. And this x-ray is taken at 72 inches. Have a good day.